Okay, we're gonna go ahead and get started, everybody. Just be mindful of everybody's time. Good afternoon. My name is
Victoria,
Yes.
my screen has a Vivian Snyder is requesting remote control.
Nope, we don't want her to be able to.
If you could just, get that off, because I don't know if other people are seeing it, but I'm seeing it. So,
Nope,
oh, you're not seeing it?
nope.
Okay, then I'll just decline it.
Yep.
Okay, there we go.
Okay. Sorry about that.
No problem.
Okay. Good afternoon. My name is Victoria Tyra, and I am the Rural Education Manager with Michigan Center for Rural Health and will be facilitating this program. I would like to welcome everyone to today's Geriatric Grand Rounds program on constipation, fact or fiction. This program is jointly provided by Michigan Center for Rural Health, MSU College of Human Medicine, MSU College of Nursing, and the also Eat Right Academy of Nutrition and Dietitians. Before we begin, and also, yeah, before we begin the program, just a couple reminders. If you are logged into the webinar portion and have your computer speakers, you can listen to the audio through them. If you're listening to the program through the audio number, handouts are located on our website for you to follow along. Our website is www.mcrh.msu.edu. Click on the education link across the top, then Grand Rounds, scroll down, find today's date, and then there you will see the presentation handouts. Continuing education is available for physicians, nurses, dietitians. Social workers, please note that we can only offer you a certificate of participation at this time. The Michigan Social Work Collaborative would not allow me to approve this program. There is a new process for physicians and social workers and dietitians. No attendance forms were needed. Your registration was your attendance form. If you attended in a group, please send me a list of everyone that attended at your site, first name, last name, and their email address. And an evaluation will be sent to you following this program. The evaluation must be completed within 2 weeks or by February 17th. If you would like to ask a question during the program, please type it into the chat box so you don't forget it, and our presenter will address it during the Q&A or when she pauses to take questions. Our speaker today indicates no conflict of interest, and the planning committee did not have any conflicts. There is no commercial support for this program, and with that, I am pleased to introduce our speaker, Dr. Catherine. I always butcher your last name. I'm sorry.
It's okay. It's Janchi.
Donchi. Okay, go ahead and take it away.
Okay, and just to let everyone know, to be interactive, I am fine with having you send in questions anytime, and Victoria can let me know when there's a question in the chat box and we can stop and talk about it. So although I realized if we have nutrition supporting us, that we should have had nutrition here, because that's a good portion of what this is all about. So anyhow, we're going to be talking about constipation, which I know is really thrilling to all of you. And it's a wonderful time while you're eating lunch, but we will go ahead with the presentation anyhow. And I'm faculty at the College of Nursing. I'm a family nurse practitioner, and I've been teaching for over 30 years. So I've been around a while, and I do see patients on a regular basis. And so I deal with this issue every day to some extent when I'm in clinic. So our objectives are to define constipation and the prevalence, to discuss the assessment that is needed to categorize the site into types, and to develop the appropriate treatment plan. So I think just a brief overview, they estimate about 15% of all adults have issues around constipation, and up to 30% of adults over the age of 65. Constipation is not a disease, it's a symptom, of course. And one of the problems with constipation is that there really isn't just one definition. There are multiple definitions, and it depends on who you ask. And I think the bigger issue is that it's often not addressed. People feel like, well, it's not important. It's just something I have to live with. It's just a product of aging, or they're embarrassed to talk about their stool, or they've been treating it on their own. So, but it does, studies show that it really does impact the quality of life. And this is the one that kind of surprised me. Constipation has a huge cost to the healthcare system. It actually costs about $145 million each year for hospital admissions related to constipation. About 2.5 million visits to providers, and hundreds of millions of dollars spent on over-the-counter laxatives. And then the state of mind. People can get very concerned about constipation and be thinking about it on a fairly regular basis. The most common constipation definition is infrequent bowel movements with difficulty passing stool that lasts for several weeks, and having less than 3 bowel movements in a week. Although the general public just feels oftentimes that it's not having a bowel movement once a day. And that is not necessarily the pattern that we expect, nor is needed in terms of a healthy lifestyle. So risk factors, being a female, aging, dehydration, physical inactivity, some medicines, lower socioeconomic status, and living with mental health issues. So you kind of think about this as a cumulative kind of thing. So in some ways, because as females get older, sometimes they're worried about, incontinence. They're not going to drink as much, they don't get out. They may not be eating as much fiber or having as much activity. So either males or females, this really does increase as you get older. There are also lots of medicines, and if you think back to that same population, many times they're on some of these medicines. Anticholinergics, opioids are huge, and if anybody is prescribed an opioid, they're supposed to be prescribed some type of a laxative along with that, but that won't be the primary discussion in this topic today. So antidepressants, calcium channel blockers, which are common hypertensive medications, even iron supplements or antispasmodics. So a lot of the medicines that we're giving for chronic pain or for mental health issues can really increase the chance of constipation. Then there are some diseases because they change the motility of the bowel. Even diabetes, hypothyroidism, multiple sclerosis, Parkinson's, stroke, and spinal cord injury. So how do we evaluate? Basically, you need to have a complete evaluation. And I think one of the problems in primary care is that we don't necessarily get the chance to do that. And we have a very short time period that people are scheduled for, and they end up we don't focus on this particular thing because they often come in with other health issues. And special consideration for the elderly is that the pathophysiology of the colon, the transit slows, the sphincter is weakened, and colorectal sensory motor function is impaired. So it's all of those things actually impact the not only the ability of the stool to pass through, but to then the defecation piece as well. And defecation is an interesting word, but a defecation history is one that you really need to get. You need to find the location and the quality and intensity, just like you do any other type of thing. The type of stool, and these are often things that people are very embarrassed to even talk about. And then how frequently do they feel the urge? Are they using enemas? Are they using laxatives? You'd be surprised at the number of people who use enemas on their own and do digital evacuation, which is something that is not recommended, but people do this because they think they have to have a bowel movement. What are their bowel habits? Do they drink enough fluids? Then reviewing the history, and then we'll go over a little bit this Bristol scale. And it helps us get a sense of the types of stools that the person is having. So this is the Bristol scale, and this is came about by the GI doctors. So the goal is the middle section. And again, I'm sure that this isn't the most thrilling thing to look at, but there are many types of stools. And we basically want to have the middle section. If you're having problems with constipation, usually it's either the hard lumpy type or hard, you know, and kind of ball almost, or the lumpy. And then some people feel like they're having diarrhea if they just have 1 or 2 stools a day, but we don't really classify that as diarrhea unless it's really very liquidy and lots of, you know, having stools all day long. So the types that you want, of course, are the sausage kind of thing that come out. And again, I know people are uncomfortable with talking about what their stools are often. The Rome criteria is also by the Gastroenterologists Association, the GI doctors. And what they did was decide that there really should be a common definition of what is constipation. And the decision was that they have a number of items here that we'll go over, but there has to be 2 or more of the following in order for them to consider it constipation. It's straining with defecation, lumpy hard stools, and that would be going back here in the type 1 or the type 2 in terms of the Bristol scale. And sensation of incomplete evacuation more than 25% of the time. A sensation of anorectal obstruction or blockage more than 25% of the time. Manual maneuvers, as I said, people do digital evacuation to try to get their bowels to move. Fewer than 3 bowel movements a week. We do expect, you know, at least 3 a week. Loose stools are rarely present without the use of the laxatives. Insufficient criteria for irritable bowel. So we'll talk just really briefly about irritable bowel. Irritable bowel has two components to it sometimes. Some people have both. There's irritable bowel where the primary symptom is diarrhea, and then there's irritable bowel where the primary symptom is constipation. And some people will go back and forth with that. But basically the other thing that happens with irritable bowel is that there is significant pain. And there's pain associated with the defecation, pain associated with the frequency of the stool or the need to go, pain associated with a change in the form of the stool. So going back to the Rome criteria, if any of those are present, then it's considered an irritable bowel, but otherwise we're looking at the constipation. There are tests that you can use for irritable bowel. And of course, when we were talking about the history, you want to make sure that there aren't any red flags like blood in the stool or losing weight or those kinds of things that might, or severe abdominal pain that would make you think you have to do some further testing. Most times we don't do testing unless there's the constipation is not responding to the regular treatment. There's something called an anorectal manometer or a rectal balloon expulsion to try to, one of the biggest things is that the sphincters themselves are not necessarily strong enough to push the bowel through. So this would help you identify that. There's also a colon transit time where they can put you swallow a capsule and they actually measure the amount of time it takes to go through the bowel. And then it would help tell them what kind of constipation you have. Then there's the barium kinds of things that they can use to look at the colon, and then a colonoscopy, of course. Although that doesn't really tell them much about the transit times or anything. So if you're going to diagnose, there's a primary and a secondary type of constipation. And the reason we were talking about those tests is that there is a slow transit time test. I mean, there's the slow transit type of diagnosis. There's the pelvic floor, as we were talking before. If you don't have the proper muscles and the sphincter, and you're not able to push the stool out, it becomes very hard and very constipated in that portion of the bowel. And then there's normal transit constipation. In order to diagnose slow transit, you would really have to do one of the capsule tests to really understand how long it's taking for the stool to pass through the colon. Secondary is looking at the medications and other health problems. And the problem, of course, there is that you're really not going to be able to make many changes there. Most people who are on these types of medications are not on it just for short-term periods, with things like gabapentin, Neurontin, other psych meds, especially the psych meds for more mental health issues like schizophrenia and all those. They actually do impact the ability of the bowel to move the transit through, and they also oftentimes will dry things out. So it's harder for the bowel to move the stool through. So just a little bit of humor, because I know this is not necessarily the funnest presentation, so just take a minute. But what it says here is, all we eat is fish. Fish has no fiber. We're all constipated, but that's why we walk funny. So the little penguins. So if you've diagnosed constipation, then how do you treat it? I think one of the challenges is so many times, really what you need to do is change lifestyle, but it's not all that easy to get people to do this. You have to assess their ability to do it. Are they able to make changes? Do they understand these things? You review the medications, as we said, and make sure that you're looking at the non-prescription medications, because oftentimes they're taking supplements that may also impact their bowel movements and things. And then the main thing is to discuss diet and encourage increasing fiber. I'll go over fiber at the end a little bit, but this is not easy to do, to get 20 to 28 grams of fiber in for women, or 30 to 38 grams of fiber for men. Most of us only get about 10 to 15 grams of fiber in a usual day. So you have to really make a concentrated effort to do this. And as we talked about before, this is often the elderly person or someone who is got other health problems. So adding this as another thing that they have to do can be a challenge. The other component of this is actually increasing fluids. In other words, increasing water. And we always talk about that, and everybody thinks they're well hydrated, but they really indicate that we should have at least 5 to 8 8-ounce glasses of water or hydrating fluids. And if you think about it, that is a lot. Now, some people are really good about having a whole thing of water and drinking it all the time. But going back to the patient, who often will be coming in, might be somebody who is even on diuretics for hypertension. So they're afraid to drink too much water because then they'll have to go to the bathroom all the time. Or someone who might have constipation, incontinence, doesn't want to drink a lot of water. And so then they actually run into problems with the constipation. So getting people to drink this amount of fluids is really a challenge, actually. Other recommendations, really, it's to encourage them to keep kind of a diary of their diet. People always feel like they're eating lots of fruits and vegetables and fiber, but it doesn't necessarily mean that that's actually happening at the levels that we expect. And then trying to find out if different types of things are causing them to be dehydrated or causing the constipation. Basically, if you can get them to do this for maybe a week, then you can kind of look at it and see, are there any correlations with any of this that we could address? One of the recommendations that was out there was to encourage patients to eat breakfast with a hot beverage to help with the reflux. And then basically you have to have a pattern. Oftentimes was what they'll tell you is that you need to have a time that you go to the bathroom, and you should go and you should, sit and have some ability to keep a regular schedule. Physical activity, we are encouraging up to 150 minutes of exercise every week, and splitting that up in different ways. And again, thinking about the more elderly patient, what kinds of exercise can they do? And it isn't necessarily about going out and doing a tremendous amount of aerobic type of exercise. It can be just walking or getting up and walking around the house. AARP has some, 20-minute videos that they can do. So it's a variety of things, but just being more active is really what it's all about. And Dr. Kyleman and I were talking about this, and she said, even for someone who is unable to get up and walk around, having somebody else help move their legs or move them to move them in some way versus just never, getting any activity at all. And one of the other things is to encourage people not to ignore the urge. The more you ignore the urge, the more problematic that can become over time. Then your body doesn't really get the sensation that it needs, and then you end up with problems with constipation again. Some other recommendations, this one's duplicate, sorry, at the beginning, but use anatomic drawings sometimes would be to help patients understand their condition and the pelvic floor and pelvic muscle strengthening that they may have to do. Some additional ideas that might be helpful is sitting, of course, we talked about briefly, sitting on the toilet. Patient needs to sit really up tall and use a small stool under their feet. And so again, the pelvic floor muscles can work the best. Yeah, ideally, you're not going to sit there and read a whole book, though. People do sometimes not take enough time to relax their body and allow the bowel movement to happen. But sitting there for an extensive amount of time isn't going to be helpful either. So to assist that pelvic floor function, patients can do some deep breathing. And deep breathing and exhaling slowly over time really helps the stomach muscles and relaxes the anus. And allow at least 20 seconds between your breaths, so that if you practice that all the time, that can help to strengthen some of those muscles in the pelvic floor. The patient should be instructed not to strain, because that causes the pelvic floor congestion and then, basically causes more problems with constipation. So let's think about fiber. How much fiber do all of you think that you get? I think one of the concerns is we're all very different, and it's hard to necessarily come up with a diet, or people want things to be written out for them, what they should take, but yet maybe they don't like what I wrote on the diet history. So one of the things that's really helpful is if you have a nutritionist, to really work with them and come up with an individualized plan. And, our extension all over the state also has some opportunities for people to learn more about their diet and lots of resources. But if you're thinking about trying to figure out how much fiber you get in, you have to be doing the, significant amount of vegetables. Let's talk about broccoli. Half a cup is 2.3 grams. Remember, we want to get almost 30 grams of fiber in a day. An apple might be 3.7. Now, baked beans, on contrast, beans and legumes really have a much higher quantity, but how many of us eat those every day? For people who are wanting to do this and kind of keep a regular pattern, one of the things is to look at some cereals that you can do in the morning. Raisin Bran might have 8.2. But like I said, that's only less than a third of what you're going to need over the day. And even you think you're doing really well for yourself when you get some basically whole wheat bread or 7-grain bread, but that's only, 3 grams of fiber. And then we often are fooled by bread because if you don't read the labels well, many times what you're really getting is very little fiber and very little whole wheat, even when they say they're a whole wheat bread. And then look at what French bread gives us, just 0.5. So to get up to that 30 is really a challenge. And kind of the last thing we were going to talk about today here is about laxatives. And laxatives are used a lot of over-counter use of these. Fiber laxatives, if it is fiber that you're trying to get in, actually there are a lot of good fiber laxatives out there. Things like Metamucil and that kind of thing. And if you use it regularly, it works. But one of the other problems is that you do need to make sure you're drinking the fluid. So if you're taking the fiber laxative but not drinking the fluid, you're not going to get the benefit. So you have to do both things and encourage people to do both things. The other thing is something like what you will see this over the, you can use the polyethylene glycol, which is actually Miralax, just so that you know kind of what we're talking about. And it is very effective and it can be used long-term. Both the fiber laxatives, Citracel, any of those kinds of things, FiberCon, they can all be used over time if that works to help people with their constipation. But again, all of them require lots of fluids as well. So you can't just drink the one glass of water that goes along with these. People often will use stool softeners as well. And it is recommended that, like I said, with certain medications that you actually prescribe a stool softener to go along with that. And then there are stimulant laxatives. These are the ones that we used to talk about not wanting to use very often. But they're finding that there really is no reason you can't use them. If people really need or feel that they have the constipation and they want to treat it, then you can certainly use these on occasion. There's no habit forming nature to them unless you're using them on a daily basis, and then it does become an issue. And then when we talked briefly about irritable bowel syndrome, these are some of the medications that are often given to patients who have irritable bowel. And usually these are prescribed more like by your gastroenterologist, initially at least, after they've done a thorough kind of evaluation to see what's going on. So I just wanted to remind you that constipation is one of the other things that caused our toilet paper shortage. And so basically, are there any questions at all?
Okay, we'll now open the floor for questions. So please feel free to unmute yourself and ask your question verbally, or you can put it into the chat box and I can ask a question for you. So we'll now take questions and comments. I kind of had something. So like when I worked in like a long-term care facility, and we would like the protocol, I think the protocol was to do like if the patient hadn't or resident hadn't had a bowel movement in like, I think it was 3 days, we'd have to, the protocol was, I think it was some kind of fiber drink or and then maybe a laxative if they still hadn't had a BM. But then sometimes we would have to lay them on, like, I think it was either their left side or their right side to help promote that. Is there any science behind that?
In terms of the laying them on a specific side, no. I mean, those are the kinds of things where we do it because it makes sense sometimes, but there's no studies. It's just like with so many of the laxatives and things. They aren't with the big pharma companies, so there aren't a lot of studies being done, and that's one of the problems with medications that are over the counter. They're not making the money from selling them, so they're not doing a lot of studies related to it.
And then there is another question that says, is there a place for probiotics to help prevent constipation?
Again, the problem there is that we think probably it may help. It certainly helps the gut in many other ways, and they often will recommend it for diarrhea. But I don't think we've had many studies that show it really impacts constipation. Although I tell my patients who are interested in taking them that it has been found to be helpful for other parts of the bowel. So it's not going to be a problem to take them. The big thing is that you have to think about what's the cost. And we are spending a lot of money on over-the-counter medications that we may or may not need. So it kind of depends on your own body too. I think we can also get some of the probiotics through more natural sources like foods, like the yogurts and some of the other things that now have cultures in them. And so thinking about doing it that way is sometimes helpful. So.
Is there a familiar connection for constipation?
Not that I'm aware of, although, many things in the bowel are familial. Like I said, the problem is that this is not a topic that's had a ton of study because it's just not, not something that a lot of the researchers are looking at. It's often thought of as just a result of aging, and it really isn't. So we do need to do more studies with it to kind of look at that. But I don't necessarily see a pattern of that, although there is, the genetic component to all the chronic diseases that we talked about. And so once you have some of those, you are going to be at more risk for the constipation. So kind of depends on how you look at it.
And then what is the chief cause of megacolon?
I'm not familiar with that term actually. So I've heard it, but I don't know enough about it to be able to tell you. And when we talked about hospitalizations, it's usually bowel blockages that are the cause of the hospitalizations. And you can get that in a variety of ways. And as you were talking about in your extended care facilities, if we're not monitoring people to make sure that they are having bowel movements, or if people are not able to really process that themselves, we have to be sure that they are, so that they don't get that blockage that's going to cause so much problems and eventually even some hospitalizations.
Mm-hmm. Do we have any other questions or comments? These are great questions. I was a comment that, like, when you were showing the slide about the fiber, it just like sparked me, like, how much fiber am I taking in just by looking at that, like making me just like go through what I've eaten and how much stuff does what I'm eating actually have fiber. We had another comment here. It says, I've heard of parent groups created against the use of Miralax in children. Any truth to Miralax having long-term effects in adults or children?
I'm not aware of any studies that have shown that. And there's not a lot of evidence around that, partly because, again, it actually isn't used hopefully all that commonly in them unless they're having some problems with other issues. The other thing is that we don't do a lot of studies on children. So you would have to be looking at studies that were looking backwards, to see if there's been any problems. But not aware that there's a lot of scientific evidence around that. And of course, the answers there are just like the answers are for everything else: more fluids, more fiber. But as we all know, with young children or any children, getting them to do what is good for them sometimes is very difficult. But usually they do encourage more things like, using prunes and adding the fiber and the fluids. Very seldom do I see them really, providers really suggesting that you use laxatives on, young children.
Mhm. I just wouldn't they have like a child approved type laxative, like, or don't they have like a child approved? No, they don't. Okay.
Not really, no. I mean, they use some of the as I said, they usually use more of a dietary changes
Mhm.
in fluids. Occasionally if it gets severe enough, then they'll recommend a laxative, but they certainly don't want that on a regular basis. And the
Mhm.
other thing is getting them more active, and that will make a huge difference as well.
Mhm. These are great. Again, these are really great questions. Do we have anything else? Any other questions or comments? Make sure I didn't miss any.
Okay. And I would say, if you know of anybody who is taking chronic opioids or pain medicines, you really do need to encourage them to take a laxative of some sort or a stool softener on a regular basis, because one of the very significant side effects for almost everyone is constipation when you're taking an opioid or a narcotic for chronic pain, or even cancer pain. People are not always warned of that, and so then they get very uncomfortable.
Is that something that your physician would like also too should warn their patient about that? Or I mean, it says it right there on the bottom on the container, like when they get it filled. But I mean, I think most physicians or nurses or anybody would recommend that they take some type of um, fiber supplement.
Yeah, or a stool softener is often what's recommended, but yeah, and actually even the guidelines for prescribing narcotics indicate that that is something that every prescriber should be doing. But one of the problems, of course, is that we are so often so busy in the clinics that it's hard to remember some of those things. And I think that's also why this topic doesn't get brought up very much. And you will be surprised if you take the time to really ask them about their history. Um, Sometimes the history is of, abuse as a child around food. And so they've really limited the kinds of foods that they eat. And they won't eat. I had one patient who wouldn't eat vegetables because he would get punished and had to, it was awful if he wouldn't eat his vegetables as a child. And so I don't know if it's just because of the fact he isn't eating the vegetables, but he's had chronic problems with constipation and has had to go to the ER for blockages. And so you have to kind of explore. It isn't just constipation. It often has a lot of other factors to it.
Well, if we don't have any other questions or comments for our presenter, we can go ahead and sign off. Please feel free to, if you think of any questions later, please feel free to either send them to me and I can pass them along to our speaker, or you can indicate them on your evaluation and I will pass those along to our speaker as well. But thank you, everybody, and have a great day. And thank you so much, Catherine, for coming over and speaking for us. It was such a great presentation.
Okay, so I'm letting you out about 5 minutes early so you can go do your walk around the wherever, even if it's inside. So get a little exercise for yourselves. So,
Yep.
okay.
Thank you.
Bye now.
Thanks.